Dr. Rupa, shall we start or do we wait for some more time?
I think, Dr. Ajam, we should start on time. It's already 1:31.
Okay.
Meanwhile, people will join.
Okay. Thank you. Good afternoon, and I welcome you all to this second session on relapse prevention. Probably there'll be one more, depending on how much we are able to cover today. So just to recap, first I'll acknowledge that I have been helped by Priyanka and Abhishek on this presentation. They have shared some content and I have incorporated that into my presentation this time as well. Now, in the previous session, we have covered a few basic things about relapse prevention. We learned about what is the difference between a lapse and relapse. We talked about why a lapse can lead to relapse. We talked about the abstinence violation effect, that is how the thought process works once somebody lapses, and then one equates it with relapse and how things move on forward. We talked about the emergency preparedness kit, cognitive restructuring of relapse and lapse. We also talk about what are the antecedents to lapse, the thoughts and the mood state that happen before the act of lapse. And we also talked about how we should address the myths that most of our patients have regarding quitting tobacco or regarding relapsing to reuse of tobacco. Now, I hope you remember this case vignette that we saw last time, and I'll be focusing on the last bullet of this. We talked about a person who had quit smoking. He was able to abstain for many months and then he resumed smoking. Now, I'm highlighting this resumed smoking because usually this resumption is something that happens in specific situations. It's not an out of a blue phenomena most of the times. It is a quite, what should I say, very systematic kind of a situation that develops, and then it puts the person at a risk to engage into smoking or reusing tobacco. And in today's session, we'll be talking about these high-risk situations, and we will also talk about how we can effectively deal with these situations. So this is the second major chunk of relapse prevention, how to help our patients deal with high-risk situations. But before that, let me ask you, what do you understand by this term, high-risk situation? Would anybody like to share their ideas? What you mean by high-risk situation? Anyone?
Anywhere the person is given a chance of using tobacco, where he can get tempted.
Okay, so
any emotional state, change in the emotional state like anger or loneliness, depression, they can also lead to the take of habit again.
Basically, the time, place, and person which can aggravate that the patient for using it. So the specific time of the day or certain group of company or a specific place would be posing it as a high risk for patients to resume their cessation, resume their activity and action the cessation process.
Okay. Any other views? Anybody else would like to add?
Whenever he links up psychosomatically, that means for his regular activities, if he is dependent for physiological activities, so that could be high risk because there's very high chance he links up that to health as well. So, for example, feeling constipated if you stop smoking, some such possibility.
So this is good because what I needed to bring out is, and that is exactly what you all are talking about, that high risk situation, many times people assume that it's a very critical situation in the sense that it has to be a big thing that happens in somebody's life. It has to be a huge event or a major crisis. And it's not actually this way. It's actually anything, any situation which puts a person on an increased risk of lapse. So it can be a very subtle thing, a very innocuous thing as well. And we need to remember a few things about high risk situations. For example, response or the solution has to be individual specific. So what it means is that when you are conducting relapse prevention for a patient, you cannot have a very generic kind of a response that same kind of an approach is not going to work for everyone. So it has to be specific for the needs of a particular individual. That is first point. Second is these situations could be stressful situations which are seen as a stressor, situations which make people comfortable. But it need not always be a stressful situation. So it could be even a non-stressful situation. So what I'm trying to highlight here is that many times we assume that if there is a stress, that's the time when we are at a higher risk of doing something that we are not expected to do. But at times there are pleasant situations, there are pleasant scenarios which can also predispose us to a risk of relapse. So many times people celebrate, and during the celebration they might resume taking cigarettes. So that is also possible. So it need not be a negative event, it can be a positive event as well. It could be a seemingly innocuous situation. For example, I might think or believe that it's a very mild thing or it's a very easy situation to be in, and I probably won't give in to that situation and I won't lapse. But we have to look at from the patient's perspective. We have to see what that situation means for that individual patient, and a seemingly innocuous situation could be a major source of stress for them. And finally, the most important point, these situations, they always happen, no matter who you are, no matter for how long you have been trying to quit, no matter how long you have been abstinent, no matter how educated you are, no matter how easy life you live, it is bound to happen to you, and it is bound to happen for everyone. So it's part and parcel of the life. So what it means is, the bottom line is that high risk situations are inevitable. So any relapse prevention intervention, if it has to work, it must start by preparing a patient beforehand for these high risk situations. So in relapse prevention, we don't wait for the situation to come. No, we prepare the client beforehand, because we know that these situations are bound to happen. It's not that it may happen or it may not happen. It will happen. It depends on an individual patient what kind of situation will prove to be a high risk for the particular patient. Now, this is the most critical question, that how do we prepare a patient for high risk situation? Now, it's not a very technically demanding technique. I mean, it's not a very something that requires rocket science. No, it requires quite simple steps, but it has to be done in a very systematic manner for it to work. Because many times we try to jump to step 5 before we are finishing step 1, and that's where the problem starts. So let's have your views. What do you think? How we can prepare a patient for a high risk situation? How can it be done? What is the best way of going about it?
So when the patient approaches you, that time when we are assessing him for his tobacco use, so while that time we can detailed interview, like where he's working, or the other situations which can these are they have a cravings or urges, like so some people have that the early morning, as soon as they wake up, they have a urge for the smoke. So that can, like, if you have a detailed when we do the assessment of the patient, During that assessment only, if we do the detailed interview for all those events, like somebody, people have a tendency that while they have a cup of tea, they go for a smoke. So all these, in this way, we can all, I might not say that's the best way, but this is one way we can prepare for high risk situations.
You should never say this is not the best way. It might be the best way. Okay, so that's one view. Good.
Yes, sir.
Anybody else?
We can reassure the patient once the patient has quit that relapse can occur, and if it occurs, that you should come back to the doctor and take advice. And this is the phase, and it will go back, and you can come back to normal. That craving will be for a very short, maybe patient, so that he will not think that he has gone back to relapse. Even if he's taken 1 or 2 cigarettes, so that can be a lab phase where he can come back to the normal quit state.
See, this we are talking about how to kind of educate them of lapse and relapse, that concept. And that's important for relapse prevention. At this point, we're talking specifically about high-risk situation. So how do we prepare a patient for handling high-risk situation?
So we educate the patient about what the problem is, and then it requires intervention. It is not a disease. It has to be modified somehow, and we have to provide him tools and opportunities, and him a supportive system. Say maybe a helpline number, which we have a smoking cessation helpline number. Or some peer or some a WhatsApp group in which all the peers are there to discuss what are the different kind of challenges they face. So we need to provide him with an environment and reassurance that this is a habit which could be modified but requires a lot of time, and you might fail most of the time, but you need to come back. And it is a lifelong process. For diabetes, you need to have it for whole of your life. You have to take medications. For smoking, you need to be on this program for whole of your life if you are having that kind of problem.
Okay, thank you, Abhishek. Anyone else? Any other views?
Another could be taking a proper history and looking at the points where he has quit before. So if we know his quitting history and maybe the maximum quit time, or probably the number of times he's relapsed for reasons which he knows already, we note them down and address those, so that we know that those were high risk at one point.
Okay. Anybody else?
Yes, sir.
Yeah.
Sir, since high risk situations are usually individual specific, as you have told, so the patient has to identify those triggering factors, and then only we can provide a support system to them how to cope with them.
Okay.
That's what I feel, because you mentioned it as it has to be individual specific. We cannot have a generic approach to these things.
Yeah, good. Very nice. Anyone else?
Triggering factor have to be.
And also, like he rightly said, once the patient sort of gives you a history of those trigger factors or those situations where he's more prone to going back to his previous habit, we can also give him or suggest substitutes, how he can avoid using tobacco at that particular point in time.
Okay.
So again, that would be individual specific. So if we have, if we give him other options in terms of distraction methods or other substitutes, then probably he'll be well prepared to face such high risk situations.
Okay. So I'll just say that for a non-psychiatrist, you have done very well, because you have touched on many important aspects for relapse prevention. But I'd like to mention one point here, that when you talk about relapse prevention, it's a very specific kind of an intervention. So many times what we confuse is that it's a non-specific intervention, and we try to think that, okay, it might involve different components from different kind of interventions. So like somebody talked about that we need to reiterate that this is a disease, it needs treatment, and that's true. There is nothing wrong with that. But actually that is what is called under psychoeducation. Psychoeducation is a different invention altogether. So it is something that we cover under psychoeducation and not under relapse prevention. Then somebody mentioned, okay, we need to give them reasons for it, motivating them, what are the factors, how things will change, how life will improve. That again is very important, but that is part of motivational interviewing. That again is not part of relapse prevention. Of course, relapse prevention will include components from all these therapies, but it's a standalone kind of an intervention in the sense that it has its own specific principles and steps. So while you are not wrong in highlighting these points, but they need to be fine-tuned a bit, and that's all that I'm going to do. But again, I reiterate the same thing, that relapse prevention is a systematic process. So all that you have said has to be done in a very systematic way. It cannot be done in a very random way. And that systematic way is quite simple. It's not very complex, but you have to go through these steps in order to ensure that you don't miss on any important aspect. For example, step 1 is, first we need to identify the high risk situation. So whenever you are trying to help somebody with high risk situation, you should know what that high risk situation is. You cannot start suggestions before knowing the problem. And that's one mistake that we tend to make. We try to help before we actually know what we are trying to help the person for. So this is the most crucial step, in fact. I would say that even more important than telling them how to deal with it, it is more important than it is important to help them identify what a high risk situation is. Now, depending on maybe the knowledge or education or intelligence or many other variables, different patients can come up with different levels of acquaintance with this concept of high risk situation. So what we need to do is, we as the first step have to list all high risk situations. I'm emphasizing all here because for most of the patients, it's not just one single situation. There are multiple high risk situations. And the effectiveness of relapse prevention depends on this step. This is the critical step, because if you miss on one particular situation and you prepare the patient for 10 others and he happens to face that one particular situation, then your intervention is waste. Because if he faces that one thing that you did not cover, it's not going to help him at all. So ensure that you list all the high risk situations. Now, again, it's very important to remember how to do this. How do we list all high risk situations? How do we do that? If you were to sit with a patient and list all high risk situations, how would you go about it? How would you do that? Now, it's your turn to speak now.
If there was any relapse in the previous time, we can ask what was the triggering factor for the person to go back to the habit again.
Okay, that's one. Second.
The time of tobacco use, like what time the person takes, either it's early morning or in the evening or after work, the time.
Very correct, very correct. So you're telling me what can be the high risk situations. That's okay. But what I'm trying to highlight here is that how do you go about it? What should be the process? What should be the we will take up the individual situations a bit later. Right now we are talking about how do we do it? What should be the process of doing it? You are a therapist, you are a qualified professional. How would you like to do it with somebody who probably doesn't even know much about it? Would you do that? Abhishek, you want to say something?
So I think first we need to sit with the patient and listen to him, what he's going through, what is his daily life routine, and how it is, where he works, what is his occupation, how is family life, and how he's going through. So maybe in that we could list what are the high risk situation he might encounter. And
that is the first important thing. Yeah. So you should let the patient speak. Now, when you work as a therapist, when you work as somebody who is trying to help somebody, you play three different roles. You are there as a helper, you are there as a facilitator, and you are there as a teacher. Now, as a therapist, you must be clear that being a teacher is the least that you should be doing with any patient. Because once you become a teacher, you assume that higher position, and then it becomes a one-way communication. And that's not what is desirable. Ideally, a therapist works more as a helper and a facilitator. And the same applies during the step one of this intervention as well. When you are listing all the high risk situation, you should let the patient prepare the list. So many times we tend to believe that I'm so experienced, I have seen so many patients, and I know it all. No, it doesn't work like that. The list is to be prepared by the patient, because we know the situations are patient specific. Now, our experience will tell us that these are the most common ones, these are the ones that are likely to happen. But even then, the patient has to prepare the list. So if the patient is literate, he can read and write, he gets the pen, he gets the pencil and the paper, and he starts writing it down. If he is illiterate, then you can help him note down, but the thought or the idea has to come from the patient. It has two benefits. A, it's likely to be more accurate, and B, the patient will own it. The moment you tell the patient, it becomes your idea. It's no longer patient's idea. And we usually don't like to be told by others. We know that what's happening in our life, and we are the best judge about it. So you let the patient prepare the list. But as a therapist, you need to facilitate the process. As I told earlier, depending on the multiple variables, the patients can differ to the extent that somebody might be very well versed with what this concept is, and somebody might know nothing about it, and he or she might depend entirely on you. So you need to facilitate, and you need to tell them that this is what we are looking for, and now think about it, and give me examples from your real life that what you think is high risk for you. You should also look at the list periodically and tell the patient that, okay, so you have covered about your work, but how about home? You have covered your home, but how about your friends? You have covered your friends, but how about the stressful situations? So you tell them that, okay, you have covered one particular area or two areas, but there is one area that you have not thought about. So you tell them, think about that. You don't tell them, okay, many people say that they are stressed at work. No, you don't tell them that, but you tell them, okay, do you think there is anything at work that might trigger it? And then they think about, okay, what it can be for me. So you help and facilitate. And at the end of the process, you can bring in your experience. I mean, there is nothing wrong in bringing in your experience, but at the end of it. So once the patient has completed it, you have helped him think about all the different domains, then you can tell them that, okay, in my experience, most of my patients have told that this is a common high risk problem for them. Do you agree with it? And if the patient says yes, then it can be brought to the list. But you must confirm. Simply because it happens with most of your patient, it does not mean it will happen with everyone. So you can bring in your experience, but before listing it there, you must confirm with the patient that do you think this is a high risk situation or not. And that must be the process that we follow to prepare the list. And that is the step one. Now, step two is again quite logical, quite simple to understand. You identify the problem, and then you identify the challenge. Now, we have talked about the high risk situation. The next step is to identify what is the challenge in that high risk situation. And now tell me, how do we do that? What is the difference between a high risk situation and the challenge in the high risk situation? Are these two similar, or are they different concepts?
Challenges are basically
Yeah, Abhishek. Then we come to
challenges are basically the roadblocks which have to be overcome to get through the high risk situations. So he have to identify what are the high risk situation is that when I go to my peers and they are smoking, so that is a high risk situation. So challenge is how to overcome that thing. So we need to the challenge is to how to avoid it, whether he has to change his company or friends, or he has to do activity in which his mind is occupied and he's not drawn to the high risk situation. So challenge is basically how to get over it.
Okay, thank you. Dr. Anna.
Yeah, so I think the challenge here is how do we cope up with, as Dr. Abhishek said, how do we cope up with those situations, high risk situations, and our coping mechanism, how do we change it in the patient, because it's his behavior, long-standing behavior. So to change that behavior over the period of time is a challenge here for the high risk situations.
Okay, thank you. Anyone else? Okay, let me ask you this way. Yeah, somebody was saying. Yeah.
The challenge will be what will be the response of the person towards the situation, whether he feels like he's very tempted towards the environment and wants to take up the habit, or whether he wants to quit the habit. Like that, I feel is a challenge, like the peer pressure and the.
Okay. See, I'll again say that you are all right, you are not wrong, but you might now tell me that I'm a bit nitpicking, but we need to understand this difference. There's a slight difference. For example, if I have to tell you that a patient tells you that for me, the high risk situation is going to a office party on a weekend. Now, this is a high risk situation. Now, what will be the challenge there? Just think about that. Whether going to the party is the challenge? No. I mean, he can go to the party. It's not a challenge. What will be the challenge there? Challenge there will be, yeah, Anupama. Yeah.
Yeah, like you said, sir, from the example, there could be many more that the patients tell. Like, for example, there's a group generally. There is an influencer always who kind of, even if he has something else in mind, but his reaction to that surrounding that environment is what is a challenge here. Probably he always makes up that in his mind that he has to quit. But is another trigger that plays against this thought, probably. That's a challenge that we need to address. So the entire thought process of this behavior change is itself the key. Maybe that's what is the challenge.
Okay. That again is not wrong. That is right. But I'll just put it this way. See, we are trying to list the high risk situation with a specific aim. And the aim is we are going to help the client to learn how to deal with it. Okay. Now, if you think that the high risk situation is going to the party, what will you tell the client or the patient? That don't go to the party? I mean, that's asking for a bit too much, no? So there we have to help him to identify the problem or the difficulty that's going to happen there. So going to the party is not the challenge. Probably the challenge will be when my boss comes to me and offers a cigarette. That's the challenge there. So in that party, everything will be fine till I'm with my juniors, because they won't dare tell me that, sir, would you like to have a cigarette? Maybe I'll just shut them off. But what will I do if my boss tells me to do that? What if my boss offers me a cigarette? That is the challenge. So what I'm trying to highlight is that you list the situations and then you help the client identify that what exactly is it that you're trying to figure out in this situation, because then you will be in a better position to tell the patient a very specific response. So rather than telling him that don't go to a party or make an excuse, you will tell them go to a party and do this when your boss comes to you. So that's the kind of difference I'm talking about. So you help the client identify the challenge that lies in that high risk situation. Another issue could be like the high risk situation is that whenever there is a lunch break and I go out, I go downstairs and my colleagues are smoking after their lunch. That happens very often in offices. So that is a high risk situation. But the challenge is when one of those colleagues is from my department who is known to me, that is where the problem will come. If the people are from other departments whom I don't know, it's not an issue for me because they are not going to offer me a cigarette. But if there is a colleague from my own department, that is the challenge in that situation. If I am seeing somebody smoke, that's a high risk situation. But the challenge there is the craving that I experience. So you need to identify the specifics in the high risk situation so that you can prepare your responses accordingly. So that is the second step. I hope it's clear to all of us now. Yeah, okay. So that is the second step. Now the third step is, what should be the third step? What should be the third logical step? You have identified the high risk situation. You've identified the exact challenge that the situation offers. What should be the third step?
How to cope up with the situation.
Coping mechanism.
Okay. So this is the problem with the default way we think, no? We jump to the solutions. But what should we do before that? Before we identify the solutions, what should we do? Yeah, the honor view 10. I don't know your name, please. Please unmute yourself. Yeah. Yeah, now please.
Dr. Ashwini.
Yeah, please.
Here, we can prioritize their challenges. It could be a single challenge, maybe many challenges, not a single. So in such case, we can prioritize which is the major challenge that the patient faces. Based on then, further we can plan.
So you're telling that, okay, we can identify that. What should we pick up for the first session and what should we leave for the second session? That's okay. But within that session, suppose you have identified the challenge, what will you do next? Yeah, Dr. Rena.
Sir, we need to, once we have identified these situations, we need to even take the patient into, I think, confidence and tell him that he needs to identify these are the warning signals as soon as these situations are come there. So we need to make him also acquaint of this, that these are the high risk situations. And accordingly, sir, we can then plan him for the relapse management.
Okay. So the third step is not actually telling the solutions. Third step is this. Before you tell them what is the right way of doing it, you need to identify what is the wrong way of doing it. So you should help the patients identify that what could be the wrong way of approaching that situation so that they know that this is not what they're supposed to do. Before you tell them that this is what you're supposed to do, you need to tell them this is not the way to approach this problem. So avoiding a departmental party might not be the right way. Or if your boss is coming towards you, just turning around, turning your back to him is not the right way because he'll find you somehow or the other. So if you are having difficulty managing your friends during the lunch break at your office, leaving your job is not the right solution. So you need to ask the patient, okay, this is the high risk situation that you have identified. This is the challenge that you have listed. Now tell me, what is it that you will do? And that will help you identify that, okay, this is not an effective way of dealing with it. So you first list what is not to be done, what is not the right way of going about it, so that the patient knows that this is something that I won't be doing if I am faced with this challenge or this situation. So that is the third step. And usually there are more than many ineffective ways of handling a situation. And you need to sit with the patient and get their views, because most of us, we know that, okay, this is what I can do. This is what I've thought about it. But we need to identify what is not the right way of doing it. And that is the step 3. So we identify the ineffective handling mechanisms for that particular high risk situation. And that brings us to the step 4, and that is what we like to do. This is where we tell them what is the effective way of handling the situation. So this is the 4th step actually. So in relapse prevention, the solution comes at a very late stage. So maybe in the 3rd session, we'll talk about how relapse prevention unfolds across sessions. It's not a single session intervention. It takes more than one session. And it's not a 10-minute session that we are talking about. You have to plan it beforehand, that what is it I'm going to do on day 1, what is it that I'm to do on day 2, what happens in session 3. So the solutions, they come at a very later stage. So we'll talk about that, how to plan the overall relapse prevention, how to do the logistics of it, what should be the content in session 1, how you should we go about session 2. So we'll take up those details, but as of now, let's talk about the effective handling mechanisms and what exactly are these. Now, this is the bulk of this presentation that we are going to learn, and we'll come to it a bit later. So we'll keep it for that stage. So this is the 4th step, where we identify the effective handling mechanisms. Should there be step 5, or is it? Have we done it all, or is there something that's still left?
So reassurance and recall, reinforcement.
Okay, maybe
following up on whether that is effective for the patient or no, even though he identified that in the session.
Okay,
it may not be helping him. So
maybe not exactly. Anybody else?
If there was any other risk situation which the patient had encountered, which was not there, was made
Okay, so yeah, you are saying that periodically you should revisit the list and you keep on adding, deleting things from it. That's very correct. But during first session on relapse prevention, should there be a step 5, or this is it? Does it cover it all? So this again is a very important thing that we need to remember and we need to learn. Relapse prevention is a skill-based intervention. It's not a knowledge-based intervention. So you are not adding on to the knowledge base of the patient. That is probably ineffective. Telling somebody that smoking kills, that usually doesn't work. That's very difficult to dissuade people from stopping smoking. That doesn't work for most of the people, because you are just informing them, you are educating them. Relapse prevention works the same way. It's not simply telling somebody, okay, this is what you should do. This is high risk situation. This is what is the wrong way of doing it, and this is the right way of doing it. No, it's never going to work. It's a skill. It's like operating on somebody. You can't just teach them by telling them. So the step 5 is actually the real relapse prevention. You need to impart the skills. So you can't simply tell them that this is what you are supposed to do. You need to teach them. You need to make them learn how to do that. And that's the challenge in relapse prevention, that you are not simply supposed to give them a list, okay, do this, do this, do this. No, you need to tell them how to do that. And we'll learn that as well. Maybe today or maybe in the next session. I hope we'll be doing it today as well. So these are the 5 steps that any relapse prevention session which is focused on high risk situation should include. Identify the challenge, identify the ineffective ways of dealing with it, identify the effective ways of dealing with it, and then teaching the patients the skill to use the effective ways. So this is the crux of it. So there are a few basic principles. Whenever we talk about telling or teaching somebody a skill, we should remember that there are a few basic principles. Whenever we are teaching somebody a skill, we should remember that not everybody learns at the same pace or with the same effectiveness or with the same ease. So the way we teach somebody a skill and the way we pace our session, it has to be based on the needs and the level of the patient. You cannot have the same training strategy for each patient. It has to be depending on the needs of a particular patient. Since it is a skill-based intervention, we cannot finish it in just 1 hour. It takes way longer than that. It takes many sessions to do this. You should teach the skills to a patient in a language that is understandable. I mean, language is just one part of it. Whether you should speak English, and it depends what the patient understands. But the kind of technicality you're bringing in, the kind of terms you're using, that also needs to be tailored to the individual's needs, how well or at what level a person can understand that. You should always pay attention because many times we start training or telling and we don't pay any attention to what the patient is going through. You should always keep an eye on what the patient's non-verbal communication is, because many times the patient might be sitting quiet and he's not objecting to what you are telling, but the non-verbal communication can tell us that the patient is not following you, or he or she doesn't feel that he can do it, or he or she is not interested. So always modify yourself in real time. Just don't go about the session you thought that you will be doing it and you don't make any modifications. No, you need to be very flexible with that as well. And you need to make it relevant. You cannot be telling a generic kind of an intervention. You need to make it relevant using specific examples and situations that the patient has provided you. So rather than telling him that this will happen to you or this might happen to you, you need to tell him that, okay, you told me that this is going to happen to you, and then I am telling you this is what you should do about it. So it has to be contextualized so that the person can think that, yes, this is something that will happen to me and I need to learn or I need to do something about it. So it should not be a hypothetical session that takes place. The patient should learn from you. That means that you have to do it for him before he or she starts doing it. So it's not simply telling them this is what you should do. It's showing them this is how it should be done. And that is done through role playing. That you assume the role of a patient and then you tell the patient or you demonstrate to the patient that this is how I would have done it. And let's discuss, do we need to modify it or how would you like to work on it? It requires practice. You tell them once, you demonstrate them once, that's not enough. It requires practice, it requires homework. So telling somebody something or training somebody on a specific skill in a restricted setting or in a safe environment like in your clinic is very different from practicing in the real world. So you should tell the client, you should tell the patient that whatever you have learned here in my clinic, you need to practice it in the real world. Otherwise, it's not going to work for you. You need to anticipate the obstacles. So many times what happens is you identify a high risk situation, you identify the obstacle, you find a solution, you tell the patient, okay, this is the way to go about it, and there is something that goes wrong. Now, we cannot predict each and everything that might go wrong, but our experience can tell us, okay, this could be something that can be an obstacle, and you need to prepare the patient beforehand. So for example, if you tell them, okay, this is what you can do if you are faced with this situation, and there is something that goes wrong, then what? So you need to anticipate these obstacles well in advance. Also, you need to explore what is called as resistance. So whenever you are trying to teach somebody or train somebody on something, many times people are not comfortable because of many reasons. They might think that they might not be able to do it, or it's too difficult for them, or it's not relevant for them. So always identify this resistance and try to work around it. So if you think that the patient feels that he can't do it, just don't stop there. You explore that, why do you think you can't do it? Can we work around that? Can we identify another way of doing it? So it has to be done in that way. And we must always remember, nobody becomes perfect at a skill in the first go. People fail many times. Actually, we are telling people to do things that they have never done in their life. Had they been using the effective strategies, they won't have ended up becoming somebody who is dependent on tobacco. They might have done otherwise, but we are telling them to do things which will help them abstain, and these are usually new things to them. So they are not going to master them in the first go, but we should always reward them for every small step that they take. So they might not be able to do it perfectly, but they might be able to do it in bits and pieces, and you should reward that performance, whatever they do, so that they feel motivated that, okay, I have done this bit and now I need to work and improve on it and I can do better than this. So that has to be done for all the skills that you are telling the patients. So this is how it works, and this is how it should happen. So you identify a high risk situation, you tell the patient how to effectively deal with it, what should be the outcome, what should happen next, what should happen next?
Success or failure.
Okay, very good. So outcome can be either this, which is what we expect, but it can also be this. So in relapse prevention, when you are training a person on how to handle a high risk situation, there has to be a plan B. So whenever you are helping a patient deal with a high risk situation, you need to tell them more than one ways. In fact, there should be a plan B, C, D, E, F, G. The more you can prepare the patient, the better or more effective he is going to be. So it shouldn't be that you tell the patient, you face a situation, do this. And what if it fails? I mean, then I can't help you. No. Then you go to plan B. What if plan B fails? Go to plan C. Because the better you prepare the patient, the less likely is that he will relapse. The less you prepare the patient, it's more likely he'll relapse. So whenever you're trying to impart skills to a patient, always tell them more than one way of going about it. So whenever your boss comes to in a party, this is what you should do. If it does not work, this is what you should do. If it does not work, then this is the third thing that you should do. You can't tell them so many things that they don't, I mean, they never lapse. It might still happen, but you would have prepared them much better rather than feeling sorry that, okay, this is what I told, and if you could not do this, that's it. No, it should not be like this. There has to be a plan B and a plan C as well. So now we are going to do the skill part of it. Okay, so there are different kind of skills that a patient needs, but usually most of them need at least one or probably all of these. One is called the refusal skills. Second is called thought stopping. The third is called problem solving. And fourth is called handling celebrations. So what we are going to do is we are going to break into smaller groups. I'll create small groups. So we have 1, 2, 3, 4, 5, 6, 7 of us. Okay. So I'll create maybe 3 groups, 2 groups of people each, and 1 group of three of us. We're going to take up 3 situations. And for that, we need to thank Dr. Rena, because she has shared with us something that we were all supposed to share, but she's the only one who has done that. So she has shared a case vignette with us. I hope you can see this. So she talks about a male patient who is 32 years old, employed with IT sector, 10 years of smoking, occasional alcohol for the last 5 years. He has tried quitting smoking 2 to 3 times in the past, but he resumes. And he has identified 3 kind of high risk situations. The first one is social pressure, that of colleagues and friends. The third is negative or the work-related stress, negative emotions. And the second is negative emotions, and the third one is positive emotional situations, for example, parties and marriages. So we are going to be into 3 groups. Let's divide these 3 situations among 3 of us, and let's discuss in those small groups, and then we'll present it to the bigger group, and we'll see that what others have to talk about it. So you have the situation, you have the challenge. Now you need to list what could be the ineffective ways of going about it, what could be the effective ways of going about it, and how you can tell a patient how to do this. These are the things that we need to do. The situation is there, the challenge is there. The first thing we need to do is what could be the ineffective way of doing it. Second is what could be the effective way of doing it. And the third is how exactly will you help the patient learn how to do it. So who's going to speak?
From group 3, we were able to discuss the ineffective and effective handling mechanisms for now, sir. So, okay. Situation number 1, so I'll start with the ineffective methods first for all the 3 situations we discussed like among all of us. So, for situation number 1, ineffective method would be to avoid such gatherings like going out with your colleagues or friends. That would be ineffective method. For
Okay.
for the second situation, quitting your job completely would be an ineffective method. Then for situation number 3, again, not going for these parties or marriages, these functions would be an ineffective handling mechanism.
Okay, let's take a pause there. So this group tells us that they have identified what could be the ineffective ways of dealing with these 3 situations. So does anybody has to comment on that, or do you want to add or say something about this? Are these really ineffective strategies? What do you think?
I think they summarized the ineffective strategies. They summarized most of it. I think
okay.
Being rude or being blunt is also.
Let me ask you one question. Suppose I decide I am this person, I am this male patient, a bit older than 32. So if I decide that okay, I won't go to this party, is it ineffective for each situation or for each one of us, or could it be effective as well for some of us?
Depending upon what is your true desire. So if you are just going there not to smoke, then that is different. And if you're going, if you're losing so many things other than that smoking part, and it will help you to socialize, meet your friends and family, and maybe an office colleague party. So just to stop the threat of smoke, you are losing on so many other things which might give a positive impact. Then it is a negative thing to do. If party, the whole purpose is to just socializing, and which is not negatively impacting your other areas of development, then not going there might be a good idea.
Okay.
So the patient has to decide whether he really wants to go or not, and then the decision would be right or wrong.
Anybody else?
It's sometimes it could be that it's not always in all the parties or all the social gatherings that he might be smoking. So it is ineffective in the sense that it doesn't hold good for every social gathering or every office party or any other social.
Okay, so basically the point is that it might be an ineffective strategy. There is nothing wrong in making that comment, but that depends on the individual and the specific party that we are talking about. So there might be some situations where, for example, you're going to a birthday party. How likely is it that you're going to smoke there with your wife being there, with children being there, and you being there in the room? So there might be a situation like that. So what the point is that you cannot have a blanket kind of a notion that any patient who comes to me, I'll say stop partying. So that is the first thing that you need to do. No, you might still party and you might be off cigarettes, but you need to see what is the risk that you perceive and how likely are the events going to turn against you. So always take that call and then make this decision. But yes, for most of the parties, it's unlikely that it will be such a safe place that you won't be tempted to take a drag or take a puff. So most it might not work, but yes, there might be situations then where it might work. Suppose your parents are there, it's a part in the family. You might not risk smoking in front of them because of the respect that you have for them. So you need to contextualize and see how it works out. What is it that this group should have done that they did not? One basic thing that they did not do right about this thing. Not right, actually. They could have done way better than what they did. So they have listed ineffective responses and they have listed one each for 3 situations. Is that adequate enough?
So this could overlap, sir. It could hold good for all 3. Some could hold good for more than
one. So
it
could overlap, but think of a party. Not going to the party is one. But is it the only ineffective way of doing this? There can be another ineffective way of doing this, no? So you go to the party, but this happens there. That again is ineffective way. So don't stop there. That I have ruled out the possibility of going to the party and then it ends there. No. So think that he might not listen to your advice, and then he goes there, and then what happens next? So always be prepared for that second step. Be prepared for the third step as well. So the more you will go into the depth of it, the more you'll realize that you know the life of the person better, and you will be able to make suggestions that really matter to the person. Otherwise it becomes a very superficial kind of intervention which practically doesn't work, because the real life might be very different from the way we help the patient interpret it. So always go beyond one. So always go to step 2, step 3, maybe step 4. The greater you put in effort at this stage, the better the outcome will be. But yeah, it's all correct. There is nothing wrong in it. Yeah, please continue. What would be the effective ways of going about it?
Okay, so the effective methods, again, we've listed one for each source. So, situation number one, the individual, so that depends on, one point would be depends on the kind of people he's going out with. If it's a close friends, then you could probably tell them openly that he's trying to quit, and they in turn, if you're understanding, and they would probably help him in his. Second could be he could give excuses like he's fasting on that particular day or something like that. So that so these methods are usually effective in avoiding any kind of force from the other party or getting habit. Then for the second situation, the person could go in for a substitutional activity or some kind of a recreational activity. Like even his office space have recreation rooms. So take breaks in between work. And in this, I had a personal view. I mean, most people did not agree with it. That maybe taking some days off from work also help at times. But if in case that is not possible, then at least taking short breaks in between work during the work hours, like indulging in these recreational activities. And for basically lifestyle changes. And for the third situation, effective method for the third situation would also be something similar to situation number one. Be with a group of individuals who themselves are maybe not indulging in this activity of smoking. Or be with a supportive, or tell them openly about your motive, or give excuses like you're fasting.
Okay.
So also the effective way might be that he can shift his timings, like when they have the colleagues and all, they can shift the timings. And also in IT companies, they have these no smoking zones. So it's my personal, like, that they are more like it's a cue for him that he'll tend to go for he will have an urge, so he can avoid those places where they have those no smoking zones. So, and we can also tell effective way might be to have a refusal skill. Like if he can directly say no, I am not, he can say that maybe later for a smoke. Like all these will be an effective way.
Okay. I'll comment on that bit later. Yeah, Abhishek, please.
So one would be to make a buddy system, which generally have take a non-smoker friend, keep it with you in these kind of inflammable situation, and that may be your saving grace, and it will take care of you. Keep in a larger companies and parties, socialize in larger groups, so in which there are more number of non-smokers as compared to smokers, and your chances of politely saying no is higher at that areas. And it's already been said by Dr. Sajan that genuinely accept that you are quitting, and when you're genuinely telling your friends, because anyhow those would be your colleagues only, and those would be the known figures in your, they might be knowing you and you might be knowing them. So the genuine confrontation of saying that I am in a cessation program and doing it for my health benefits or health issues, people might you after some time. So you have to be true and make a buddy system.
Okay. Anyone else who would like to make a comment Yeah, Dr. Ashwini.
Is a situation of positive conditional situations. Some relatives may make us very happy, and they, like relatives, being with relatives, stop them to indulge in those activities. What I feel, only those group where you feel nice.
Okay. Okay, so this is all very good and very correct. Absolutely not absolute, almost nothing wrong with any of the ideas that you gave me. But what we need to remember is one, like we need to be very particular with the way we put things across when we talk to a person. The group at NICPR said, the second response that they gave was, make an excuse. Now, when do we make an excuse? When do we make an excuse in our life? When we have done something right or something wrong?
Something wrong, generally.
Something wrong.
Remaining abstinent from cigarettes is nothing wrong. So rather than making excuse, you need to give reasons. So there is a slight difference there. So you never make excuses for something good that you're doing. So you need to tell the client, don't make excuses. Be upfront. Straight away say no. Because you are saying no for a good cause. It's not that you are doing something wrong and then you need to do something. That's one thing. Another point that came up was Dr. Raina said that. What is it that you said, Dr. Raina? Can you repeat that?
The time shift and shifting their timings and to avoid those non-smoking zones. That's what
you said something else as well.
And so, yeah, that to develop the refusal skills, that maybe like don't directly say no, or
maybe later.
Like if he has some senior or some senior is in there, so if he can't directly say no.
Maybe later, again, is not the good way of doing it. Maybe it means that you have given the other person a hope that, okay, you can ask me again. So when it comes to refusal skills, and we'll talk about that in the next session, it has to be as straight and as blunt no as it can be. So that the person who is offering you a cigarette knows that he should not do it again because it's not going to work. If you say that maybe later, it means that maybe शाम को try दोबारा कर सकता हूँ, maybe अगली बार पूछोगे तो शायद मान जाऊंगा. So you are kind of giving the other person a reason to get back to you on the same thing. It's better to be upfront and say, no, I am not smoking these days. I have quit it, and that's why I'm not going to smoke it with you as well. So it's better to be that clear in your approach. Anybody else who would like to add anything? Okay, what is the third step of it? How will you exactly go about it? How will you do these things? I mean, these are the ways the patient can do it, but how are you going to teach or train the patient about this? Okay, that's big silence now.
So there is one, yeah.
Please.
One we had planned of yoga and meditation, lifestyle modification that can be made with.
Okay. Mm-hmm. What else?
The second one is Hello?
Yeah, that's okay. Please carry on. So yoga is one. What else?
He can probably stop offering cigarettes to others. So, that can act in a sort of a reinforcement. Like if he's used to, if he's pointing social pressure as a reason, that means that it's a mutual thing. So if some friend is forcing him, so he can stop offering them. Maybe that can act as a way for him to move away.
Okay. So I think let's stop here and let's keep it for the next one. Okay. Thanks for joining in. See you again.